Hi, I'm Dr. David Kolko, and I want to just say a little bit about how we screen families who are being considered for AFCBT. We have tried to specify some eligibility criteria because the point of this is to figure out which families are going to respond to AFCBT, which families are appropriate for AFCBT, based on what we've done in research and based on our clinical experience. So the first slide I want to just highlight for a moment are the broad screening criteria that we have laid out for AFCBT, and then I'll show you some slides with specific criteria and explain them. So the first three criteria are really demographic in nature. So we're looking for primarily children or teens between the ages of 5 and 17, and the reason is that our research literature covers this age range. So that's the age range we generally recommend for AFCBT. We also look for a caregiver. It does not have to be a parent. It doesn't have to be the biological parent, in other words. It could be a foster parent. It could be a kinship care. It could be another relative. It could be someone else. We are not necessarily looking only for, a biological caregiver. And in many cases, sometimes there are no biological caregivers. There are other caregivers, and so we are going to work with the caregiver that is available to work with this child and the therapist. And then we look for a scenario in which that caregiver and that child seem appropriate for being included in a treatment like this, which is designed to help them improve their relationship. Now, we know sometimes caregivers might not be available. They may not be appropriate. They may need other treatments that are required before they can participate in AFCBT. But we're really looking for a parent who is hopefully available to work with this child, either now or in the future. And secondly, we're looking for a parent and a child who can eventually be reunified if they've been separated. So then on the caregiver side, in terms of clinical inclusion criteria, what do we look for? Well, one thing we look for is those caregivers who have an allegation or report of suspected physical abuse, or they have done something that's resulted in or could have resulted in injury or harm to that child. We also look for a caregiver who has possibly used some type of physical force, sometimes excessive or harsh, physical discipline with a child. And finally, we look for a caregiver who may be involved in conflicts or very significant arguments, especially frequent arguments with a given child or a teenager. And in those scenarios, we sometimes see that those caregivers are engaging in a fair amount of verbal, emotional abuse, in other words. So it could even be the case that this is a caregiver who's simply highly verbally aggressive, even if they aren't necessarily using physical force. On the child side, we look for children who have a pattern of oppositional behavior, who are argumentative, or who may have other explosive or angry behaviors. Second, we look for children who may be verbally or physically aggressive, or who have other high-risk behaviors. We could also find a child appropriate for AFCBT who is exhibiting trauma symptoms, especially trauma symptoms secondary to exposure to physical abuse or physical force. And then finally, we could find a child who has had a history of conflict, perhaps even in a prior family. And so that child may have either been involved in a fair amount of conflict or exposure to harsh or punitive physical discipline, or may even have been physically abused and injured by a caregiver. Even if this child has had that history and they are no longer with a caregiver who has engaged in any of those behaviors, that child may still benefit from AFCBT with a non-offending supportive caregiver. So those are the primary criteria that we use for AFCBT. And what I want to just show you very quickly are those separate criteria and suggest to you that you think a little bit about in what ways you would be challenged to address these three items. This is one of the things that we will discuss in another segment, which is how best to understand and interpret these criteria. Whether or not they can participate together and benefit is something that will take some time to understand in certain cases. I just want to show you a little bit more specifically those 4 criteria I mentioned about the caregiver. And obviously this cuts across a pretty wide range of caregiver behavior. Yes, on the one hand, it does include actual physical abuse, but it includes many other caregiver behaviors that don't necessarily reflect physical abuse, including just using everyday physical discipline. It also includes just everyday conflicts, arguments, heated ones though, but nonetheless the kinds of conflicts and arguments that most typical families might experience. And then finally, I want to just highlight a couple of things about the child and the teen that might be referred for AFCBT. And what you can see here is that we really are talking about a range of behaviors exhibited by the child, mostly on the externalizing side, like oppositional and aggressive behavior. But we also could take a case who has primarily internalizing or emotional symptoms such as PTS or PTSD, secondary to physical abuse or some type of physical force. Now, even if this child doesn't show any symptoms, behavioral or emotional, if this is a child who has had this history of exposure to these physically abusive or verbally abusive interactions, or they've been actually exposed to physical abuse, that alone may make it reasonable to consider a family for AFCBT. So I hope this just gives a general overview of the main criteria, and in a later segment, what our colleague Barbara Bauman will do is to really review in detail some of the ways in which these criteria need to be clarified and some of the challenges that come up when you're trying to execute those criteria with a given family.
Hi, I'm David Kolko, and I'm going to talk about the role of clinical assessment in AFCBT. And what I'll focus on are the instruments that we recommend for AFCBT and their interpretation. And the hope, of course, is that this information will help you select the right cases, target problems that AFCBT addresses, and then determine that you have improved those particular targets. So why do we recommend these instruments? Why use them? One reason is that using these instruments will help to identify the types of problems that AFCBT is designed to target. The second is that having this information will allow you not only to identify the problems that you're really most concerned about, but you'll be able to evaluate and track those particular outcomes by the end of treatment. And that's going to help you determine in what way the family responded or didn't respond. A third benefit is that you can collect information and over time be able to demonstrate some support for this model by looking at outcomes before and after the intervention is used. The hope, of course, is that families improve. Many families we see do improve, and that by using these instruments, you would be able to document these types of improvements. The final reason has to do with system requirements. There are many programs now working in settings or in municipalities or in states that now require more evidence of accountability, and part of that accountability deals with the collection of outcome information or outcome evidence in order to demonstrate the benefits of a given intervention. So how do we use these instruments? What guidelines can we offer you when you're going to administer each of these instruments to either a child or a caregiver? We think the first thing is to make it clear why you're collecting the information in the first place. How are you going to use this information? How will it help you? And obviously, a family would want to know that this information is going to help clarify the specific problems that you're going to focus on. Another condition is to make sure that the environment, the office in which you're working, or the setting in which you're working, is very nicely organized, is free from distraction, is quiet, and that you're organized, that you have all your materials and whatever you need to do the assessment. We also want to make sure that we promote a context for giving us accurate information. We want the respondent, whether it's a child or a caregiver, to feel comfortable, to make sure that they're able to provide us with information that we need, and that they feel committed to giving us accurate information. We want to make sure that they're comfortable with whatever is the data collection method, So sometimes the method is filling out a form. Sometimes the method is working on some type of computer or notebook, or there might be some other method. And of course, with every method comes both advantages and disadvantages, and we want to make sure that a parent or a child is comfortable utilizing the technique that we're going to use to collect the information. So if it involves the internet, of course, that requires a certain amount of sophistication. If it involves using a questionnaire that they're going to complete, well, someone has to have physical ability, of course, and they have to be able to read. So each of these methods requires some degree of investigation on our part to make sure that the parent or the child is comfortable completing the instrument using that method. We want to also make sure that they understand that we're going to share the results and we're going to discuss them. That this is information, of course, that you're getting from the respondent, but you're going to provide information and feedback as you get it, and you're going to verify that the information you're getting is accurate and useful. You want to also solicit questions when you're done. You want the caregiver or the child to feel comfortable asking you questions, or let's say if they felt uncomfortable with some of the content, you'd want them to feel free telling you that, so that you have a conversation about why those items were used, but also you can apologize or indicate why you're not trying to make them feel uncomfortable, you're just trying to get information. So there are a couple of issues or challenges to administering these instruments which clinicians sometimes experience. And one is that it sometimes is difficult for them to maintain consistency in their administration. And that could be because the answers they're getting are either provocative or they're very sensitive. And sometimes we respond to those answers, even though we're trying really not to be a clinician here. We're trying to be an accurate assessor and a fairly neutral assessor who's able to collect information and then provide a summary in return. So sometimes when parents say certain things that might be offensive, for example, or that we might find difficult, we might respond to the parents or the child's responses in a way that conveys some kind of feedback to the child as to whether we're upset or not. And that's something which is difficult for us to manage, but it is something that we really have to work on. The second one is that we have to clarify answers that aren't quite sufficient. You know, sometimes people give answers that are not on the scale, or they give two answers, that are next to each other. And it really is our job to just simply ask them which answer they want to give, or to say back to them the answer they gave and to say, well, is this what you meant? Or to try to put it in words that will help them give you an answer that fits the scale or the dimension that you're trying to administer. And then the third challenge sometimes is addressing what we perceive to be limited interest. Someone who really doesn't seem to care. They're looking off to the side. They're giving answers that aren't even on the scale. They have a look of, well, I don't really care about this. And that disinterest is, of course, a challenge for us because it's hard for us to say, hey, it sounds like you're not interested. On the other hand, it might be reasonable to just simply stop for a moment and ask someone if they need a break, or do they need a moment, or is this really long? I mean, it is important for us to be sensitive to their own experience during the administration of these instruments, just as we're going to do this during the administration of AFCBT. So it seems important to acknowledge this if this is what you discriminate, and to try to figure out if there's something else that can be done to actually either change the situation or give them a break, and hopefully get to a point where the respondent is now more engaged and more motivated to give you accurate information. So what are some of the assessment measures that we administer in AFCBT? The first is the Alabama Parenting Questionnaire, and that is administered to caregivers and should take roughly about 10 minutes. And this asks questions about positive and negative parenting, and I'll go through some of the details of the instrument shortly. The second is the brief Child Abuse Potential Inventory, which is again administered to the caregiver and should take about 5 minutes. And this asks questions that help to capture information that tells us if this is an individual who is responding similar to other individuals who are at high risk for either abuse or for using physical discipline. The third scale is the Strengths and Difficulties Questionnaire, the STQ. This is also administered to the caregiver. Should take about 10 minutes. And this asks questions about child behavioral and emotional problems as well as social skill and peer problems. And then finally, the Child PTSD Symptom Scale, the CPSS, is administered to the child in order to learn information about the likelihood that that child has symptoms consistent with those individuals who have post-traumatic stress disorder. And this should take about 10 minutes. So this is an example of the APQ that is administered to caregivers, and we just wanted you to see some of the content. This instrument has 42 items, and it's rated on a 5-point scale, and you can see some of the examples. And again, they're common parenting practices, some that we perceive to be positive and some that we believe to be more negative. And we're interested, obviously, in learning about the use of both because we're going to be targeting both. The BCAP, the Brief Child Abuse Potential Inventory, is actually a shorthand version of the longer Child Abuse Potential Inventory, and it includes 24 items that you can use to also identify whether the responses of this person sound similar to those of other known physically abusive caregivers. And they capture, personal distress, dissatisfaction, depression, irritability, and family conflicts, as well as some other scales that deal with whether or not this person is answering consistent with most people or whether or not their answers are really unusual, and that's used for validity purposes. The SDQ has 25 items that are broken up into 5 subscales that capture behavioral and emotional problems as well as social and peer problems. And these are routinely administered to caregivers in order to provide some kind of estimate of the level of mental health problems seen in the child being referred to you. And as you can see, this is a 3-point scale. Now, the CPSS has 2 parts. One part is a trauma screen, which identifies likely traumatic experiences, events that this child has witnessed or come in contact with. And this is first to identify whether or not the child has been exposed to traumatic events, and if so, to how many different types of traumatic events. But the second part asks about post-traumatic stress disorder related questions. There are 17 of them, and they're rated on a 4-point scale. And this provides you with an index of the degree to which this child is reporting symptoms consistent with post-traumatic stress disorder or PTSD. This slide shows you the types of clinical cutoffs that you'll use in order to determine whether or not a given problem exceeds a cutoff or whether a given competency is lower than a cutoff. Either one of those might be reason for addressing that particular issue in AFCBT. So, for example, on the APQ, if a caregiver's score on the corporal punishment subscale is greater than or equal to 7, that's an indication that this is a clinically meaningful, a clinically significant level of corporal punishment that might warrant intervention. Likewise, if a parent has given a score on the positive parenting practices scale that is 21 or lower, that's an indication that this is a low level of positive parenting, and it too would therefore be grounds for targeting an AFCBT. On the BCAP, a caregiver may get a score greater than or equal to 9 on the abuse risk scale, and that would be an indication that this is warranting some type of clinical intervention. Also, there is a small family conflict scale, and a score of 2 or greater would suggest that there's a modest to high level of conflict in the family that might warrant clinical intervention. Now, on the SDQ, we mostly look at the conduct problem scale score. And if that score is greater than or equal to 4, that's an indication that that's a modest to high level of clinical concern regarding the child's behavioral problems. And again, if that was the case, that would suggest the need to intervene to address the child's conduct problems or behavior problems. And then finally, a child whose PTSD symptom scale is greater than or equal to 15 would be reporting a severity level that would warrant clinical intervention. So hopefully this table can allow you to interpret the meaning of the scores that you get and then to make decisions about where you're going to intervene using AFCBT. Now we have on our website an automated assessment scoring program, and this scoring program you can access through the web. You need to have Java as a supporting program on your notebook or PC. And if you have it, then you can actually execute this scoring program right from your laptop or your desktop. And what this allows you to do is to enter the scores that the parent or the child gives you on each instrument, and then what you can do is hit a button and calculate the clinical cutoffs, and it will tell you whether or not you're above a clinical cutoff. And then you can print the actual document so that you can have this for your record or to review with the family. And this is available in the download section of the AFCBT website once you have entered your username and password. Now I want to just go over briefly a case that participated in an assessment just to show you how we use the information. And this is the case of Danny, and he's a 10-year-old African-American boy. He's living in the inner city. He lives with his mother, who is the caregiver, and two siblings who are ages 4 and 6. And in terms of his trauma history, he was physically abused by his mom. She reported that she gave him daily whoopings, which involved hitting him with her hand, and sort of like she described as a spanking. In addition, she assigned to him certain jobs and chores when he misbehaved, so he had to clean and spend a fair amount of time doing something like that. Also, there was a history of domestic violence between mom and her ex-boyfriend. Now here are the results on those 4 instruments, and you can see the APQ positive parenting score is a 14, the corporal punishment score is an 11, on the BCAP the abuse risk score is a 13, the family conflict score is a 3, on the SDQ the conduct problem score is a 7, and then finally on the child reported CPSS the score in total is a 7, and there are just mostly arousal symptoms being reported. So if you think about those scores, and look at the cutoff scores, then you could ask the question, which ones seem to meet the clinical cutoff? And of course, one of the questions is, if we were to do this as an exercise, which scores are of clinical concern? And if you are able to remember the cut scores, the clinical scores for cutoffs, what you realize is that all of them actually met a clinical cutoff, except for the CPSS, which was below the clinical cutoff of 15. But all the other ones are high. So if we were to ask the question, what would be your next step? Well, one of them might be to provide some feedback about all of these clinically meaningful, clinically worthy scales, and to use that information to help identify problems and possibly targets that you might work on with this family, all of which would be consistent with the content of AFCBT. And I wanted to ask you, have you seen families like this? You probably have, or maybe if you're newer to this area, you haven't seen that many. But it's important to now think back about your experiences and the families you've seen, and if they had some of the same clinical characteristics, then you could at least be thinking about, well, what did I do for them that was successful? And bring that information to your conversation with this family about these clinical issues and the possible benefit of AFCBT. There are also pros and cons to doing an assessment. Sometimes we recognize that families see the advantages of being involved in an assessment because it can help to identify the targets they're going to work on, and it provides you with guidelines for what you're going to do in AFCBT. But we also understand that parents sometimes or children aren't necessarily up for an assessment. They sometimes find it difficult, boring, or a challenge. And that is also true for us as clinicians. Sometimes we know we don't have enough time, or we're trying to do it very quickly. And so we can appreciate how with any assessment we do, there might be advantages and disadvantages, and it's really important to recognize that.
Hi, my name is Barbara Baumann, and I'm a trainer and consultant for AFCBT. Today I'm going to be talking to you about the appropriateness of different cases for this model so that you can help to make a determination of which cases on your caseload would be appropriate. AFCBT generally is appropriate for children ages 5 through 17 who have a caregiver who will participate in services. But this might be easier said than done. As we know, we have lots of kids, lots of caregivers, and lots of settings. So let me go through a few criteria with you. First, let's think about settings. AFCBT has been used with children who are in their biological homes, foster or resource homes, kinship care, residential setting, group homes, and shelters. It can also be used by school counselors or therapists in the community who work out of the school. We have found all of these settings seem appropriate for the use of AFCBT. Different modifications may need to be made, and we have available supplemental materials to help with special populations, such as those in foster care. What about the caregivers? So we want to think about who is going to participate in treatment. As you've seen, an appropriate criteria for AFCBT is that we do have a caregiver who is going to participate with the child. The structure emphasizes a family or a family-type unit. The child and parent do not have to be living together, and it does not have to be their biological parent who participates in treatment. It can be the offending caregiver if the child is in due to some type of offense, as such as an abuse or neglect charge. But you can also have the non-offending parent. Perhaps that's the parent who's willing and able to come into treatment. That would work out well as well. How about the biological parent? That's always an option. But you can also engage a foster parent, a foster mother, foster father, someone who's able to take the time to meet with you on a regular basis to provide treatment for the child. This treatment that you're working with the parent on is supportive of what's going on with the child, and that's how we talk to the non-biological parents often if they're hesitant to become involved. Perhaps they feel that their foster child will only be with them for a short time, or the child's placement is unsure at this point. That's okay. We try and engage who we have at the moment who can be supportive to the child. It could be the child is in relative care, and we're looking then for one of the relatives who's with them to be able to come forward as that support person, to be a stand-in for the biological parent. And lastly, we may find just a supportive adult who has routine contact with the child. It could be a relative, it could be a group home worker, it could be somebody who resides in the residential home with the child. We're looking for a supportive adult to be the caregiver or to stand in for the caregiver. What about children? We're looking at the identified or referred child, of course, as your client, but we may also look to their siblings and include their siblings if that's appropriate for our setting and for our funding source, and if it will add to the treatment for the child and the family. We're looking for children, even if they only exhibit the behavior in one setting. Perhaps the parent tells you that they are fine at home, but they have a problem at school. Perhaps one parent tells you that the parent problem is only in the other parent's home and not in theirs. That's okay. We can still work with the one parent in the one home for helping the child, even if the child's behaviors are in the other home, because we're going to help the parent to be supportive of the child all of the time. So when we're looking at eligible cases, it could be a new client with whom you're just beginning services. It could be a continuing client that you've tried some other treatments with and that you'd like to now switch over to AFCBT. It could be a returning client who you did AFCBT or a different type of treatment with the last time they were in, or a client transferred to you by another clinician who perhaps is leaving that case or leaving your agency. We can even work with family members who are receiving services from multiple providers, as that happens a lot of time with the families in the system. It may even be that someone in your own agency is seeing one member of the family and you're seeing another. We work to be collaborative with the other professionals involved with the family. We take a family approach, as you can see. We're open to working with multiple family members or with one family member. We're trying to get as much support as we can within the home for the child. We envision the parental work as supportive and essential to change within the family.
Hi, I'm David Kolko. In this section, we're going to review a case example of AFCBT. This is a case which is very similar to many of the cases that have been treated with AFCBT, and we thought it would be a good idea to give you a sense of the content and a little bit of the outcome of this particular case. So this is the case we'll call JR. JR was 11, Caucasian, a boy with ADHD, ODD, and MDD, so 3 different Axis 1 psychiatric disorders. He was recently referred for an incident involving child physical abuse in which his dad yelled, cursed, threatened him, and then kicked JR in the face. It left bruises on his back and stomach, and he also broke his glasses, and he had facial cuts. The brother, the younger brother, actually observed this incident. The family had a history of divorce, domestic violence, emotional abuse, and shared custody. The mom also had diagnoses. Those were bipolar, alcoholism, post-traumatic stress disorder. She was also taking medication for her PTSD. And then the dad lived with his girlfriend. He also had been diagnosed with ADHD as well as anxiety, and he had frequent irritability. So these are some of the results of the instruments that we've encouraged the clinicians to use. And this is from the Alabama Parenting Questionnaire. And on that questionnaire, the caregivers both reported low positive parenting, low involvement with their child, and high levels of corporal punishment. JR had completed a PTSD measure, the UCLA Reaction Index, and his score suggested a partial diagnosis of PTSD. Now this slide is a reflection of the 3 phases of AFCBT, and what you can see is the content that a family would receive in each of the 3 phases, with the green content at the bottom being the first phase, the orange content in the middle is the second phase, and then the final and third phase is listed in purple. And I just want to show this to you so that you would be oriented to the kinds of content I'm going to talk about in a minute that were administered to this client. So here in a nutshell is a summary of the treatment information, the content that was delivered, and a little bit about the course of treatment. So in the first session, the mother came with JR, received our usual orientation. It was determined that a safety plan was necessary. But also, interestingly, the dad, who was supposed to show, did not show to this session. In the second session, the mom returned, and the clinician reviewed stressful life events, and then did a pro and con analysis using decisional balance to help her understand the pros and cons of either returning for treatment or not returning for treatment. In the third session, the dad actually came, and we did the same decisional balance as well, where the therapist reviewed the pros and cons of coming into therapy and returning or not. He reported being embarrassed and feeling shame because of what he did to JR. So the therapist provided him with some psychoeducation about the role of violence and abuse and the impact on children as well as the impact on adults. Talked to him about making an agreement to use less force in the future, and did something like the weekly safety check-in, where she started the process of learning about those positive and negative interactions that had occurred in the prior week. In the fourth session, JR talked about his emotions The clinician reviewed emotion identification, especially around anger, read him a story about a child who had been physically abused, and that seemed to prompt him to talk a little bit about the incident involving his dad, where he concluded at the very end that it wasn't his fault. In the fifth session, Dad came in with JR, and they discussed the use of physical force and discipline, and the dad spontaneously apologized for what he had done. And so at this point, there was an option to follow up on his apology by having him review a clarification letter and a note that he had written. And because the therapist felt that this was genuine and the right time, he was able to do this. And as a result, JR expressed feelings and views about the note, saying that he felt glad that his dad was starting to change. And in the seventh session, the mom came in with JR. She also prepared her own apology and her own statements, but she also was prepared for reading the note that the father had written. And the mom had begun to say that there were benefits she was noticing in her son. So in the second phase of AFCBT, JR came back and they reviewed the ABC worksheet. They talked about thoughts, an alternative to thoughts, to help him control his angry mood, because sometimes the thoughts he had seemed to make him more angry. The dad in the ninth session did something very similar, and the clinician worked out with him certain automatic thoughts that he had identified, for which she also tried to identify alternatives to get him to think in a different way. And in particular, they talked about having more reasonable expectations regarding his 11-year-old son. In the 10th session, JR did more emotion regulation work. We did some psychoeducation around how the body responds to anger and anxiety. He was taught some relaxation skills. Dad, it turned out, received the same content, and he too also learned how to relax, but he also learned how to use deep breathing. Then JR came back for the 11th session, where the clinician reviewed social skills, did some role plays, and then the dad had a bit of a session where they reviewed rewards and praise. They did some role plays to get the dad used to doing this, which of course he wasn't used to doing, and he later at the end said that he had felt weird doing something like this and issuing praise. In the 12th session, the dad came back. This time the mom is there, and they reviewed rewards, the use of rewards with JR, and issuing effective commands. And the clinician noted that they had very different styles. The dad was far more controlling and punitive, and the mom was much more relaxed and passive. In the 13th session, Dad came back with Mom, and they reviewed effective discipline, and they had talked about the practice assignments that they had worked on, and the clinician highlighted the importance of following through, not just deciding that you're going to learn a skill, but also use the skill, practice the skill, and make sure the skill is executed on a regular basis. In the 14th session, Dad came back with JR, and they worked on their communication. They discussed the fact that they each had communication obstacles. They identified some of the communication problems that each of them faced, and that each of them recognized in one another. But they also identified alternative skills to communicate more effectively and practice them. Then in the 15th session, the dad was back with JR. They reviewed some problem-solving scenarios that they worked on. They reviewed the skills that they applied and how well that scenario was addressed. And then there was some psychoeducation around ADHD. And you'll remember that both JR and his dad had been diagnosed with ADHD. In the 16th session, the dad came back with JR. They reviewed some additional examples from their problem-solving routines that they were using. And of course, by now, the hope is that this is becoming a general pattern that they can follow on their own, that they know the skills and will actually use them with one another. In the final session, Dad and JR came back for a graduation exercise where they reviewed the skills that they had learned and were able to comment on those skills. And then Dad had said at the very end that he had learned a lot, and it appeared to this clinician that he had really made a lot of progress. Now, it might be interesting to look at some of the before and after scores of the case. And what you can see here is that in terms of services, this family received 17 sessions in about 22 weeks. And on the APQ, JR had been actually given this instrument as well as the dad. So we're going to report to you the scores from both informants. And what you can see is that JR is reporting an increase in positive parenting, just as his dad is. JR is reporting more positive involvement with his father, and the dad acknowledges the same thing. JR reported a reduction in inconsistent discipline, and the dad also reports less inconsistent discipline. And finally, JR reported a reduction in corporal punishment, which the dad also acknowledged. So there was very nice agreement between JR and his father regarding the improvements. And what you see is that some of these behaviors are adaptive skills, they're competencies, they're desirable, and we want to increase them. And others are undesirable, they're unwanted, and we want to decrease them. And you see both of those taking place here. Now on the UCLA Reaction Index, the PTSD measure, JR's reports originally put him in the partial diagnosis range, and now he is in the non-clinical range at the end of treatment. Now the mom just happened to mention a couple of things. She said that there was better communication. She said that the child's mood had improved, and that both of them actually were behaving far more appropriately and safely. So let me just offer a couple of comments about the case, as well as highlight a few of the challenges. One is that it was really important to make sure that we got dad engaged with JR and mom, and that they were all on board. As I mentioned earlier, neither the mom nor the dad really bought into the therapy model or the idea of therapy in the first place. So it's very important to review the pro and con of coming back and the decisional balance in order to help figure out whether the parents really did want to come back and initiate treatment. It was important to get dad and JR in the same session. They had a daily visitation schedule whereby the JR was occasionally with his dad, and then the next day with his mother, and then back to his dad, and then back to his mother. You can appreciate how chaotic this was. So it was really critical to make sure, because dad was the perpetrator, that he was going to get into session, then he was going to learn skills, and then he was going to eventually be with JR in the same session so they could use the skills with one another. Now there was also a concern about ongoing violence or concerns about safety. We didn't know if that would be JR's safety, the mom's safety, the dad's safety, all of their safety. So as a result, there were safety plans set up, and there was a monitoring of safety issues throughout treatment. And this is something which is common in cases receiving AFCBT, which is we always have to keep an eye on dealing with violence and safety issues. The fourth was that we needed to coordinate information among several providers. It turned out in this case there were 6. And so it was really important for the clinician to be in touch with all these other providers, simply to make sure that they were on the same page and that what they were doing was coordinated. And then finally, it was important to provide some information about ADHD. As I mentioned, both JR and his dad were diagnosed with ADHD. Neither one was on medication. And maybe just as importantly, neither one understood what ADHD meant. So it was really important to provide some of that information. That isn't obviously what AFCBT formally does. It just seemed to be a logical, sensible, and therapeutically beneficial thing to do. So this is basically a typical case referred for physical abuse that was treated with AFCBT and fortunately had good outcome. And we hope this provides you with some sample of not only what's the content of AFCBT, but what are the likely outcomes you're going to experience.
And finally, we'd like to just give you a quick update as to this case. This case was treated in 2011 to 2012. And at that time, we had the second edition of AFCBT. And so some of the content was a little bit different than it is now. The main difference was that clarification could be done in the first phase or the last phase in the second edition. But in the current edition, we usually recommend that clarification be done in the third phase, meaning later on in treatment. We wanted to just make that comment before we go on with the rest of our orientation video. In addition, we thought we would mention that this particular case was published in a book edited by Urquiza and Timmer, and the citation is listed here at the bottom of the slide. And for those of you interested, you could certainly look at more details and more descriptions of both the procedures and the challenges and issues that the clinician faced in this case.